Welcome everyone. Cultural Awareness Seminar number, I'm not sure the number now, the first one of the 2006 season. We're very grateful to have Professor Syndie David. She's joining us from McGill University. She's an assistant professor at McGill University. She just received her PhD in social work in 2024 at UQAM, and her supervisor was the well-known Henri Dorville. I think he was the founder of the cultural consultation service at Jean Talon. The title of Professor David's thesis was Santé mentale et communauté noire, expérience de traitement de la maladie dans la communauté afro-antillaise du Grand Montréal. So she's been a social worker for 20 years. She's worked primarily with racialized youth and immigrant families. Her research includes the impact of social representations of mental illness on help-seeking behaviors and treatment options in Afro-descendant communities. So she's going to be talking to us about Black experiences in mental health treatment, reframing social representations as sources of strength. So we're grateful to have you, Professor David. And we could maybe try, if people can turn their, anyway, maybe people can't do it today, do a brief intro. But normally you would present till probably, I don't know, maybe 22, quarter to, then we have a discussion about certain issues you've raised. So that's kind of how we'll go.
Sounds good. Well, thank you for inviting me here today. I'm quite excited to be here. I hope everyone hears me. I think sometimes the internet gets shoddy. So let me know if you can't follow me.
I can hear.
Right. Perfect. Okay. Perfect. And you all can see my screen?
Yeah, that's the slide show right there. We have the slide.
Okay. Perfect. All right. Well, yes. So thank you for having me here today. Hopefully, if I manage to get the quarter of what's in my brain and what I want to discuss today out, it will have been a good session. So of course, introductions. Well, Dr. Jarvis has done a good job of digging out my where I'm coming from in terms of my thesis and where I'm at today. And so I am coming at this with kind of three perspectives in terms of, yes, my research study related to the social representations of mental health and illness and the impact on treatment in Afro-Caribbean communities, and also my years of practice, which is 20 years now. I don't know where the years went and how that happened, but here we are in different and varying sectors of social services, and particularly the 15 years that I've been at Côte des Neiges as a clinical social worker with youth and families. And I had left, and then I was lucky enough to come back. So I'm also back as a first-line social worker again with youth and families at CLSC Côte des Neiges. And in terms of also my teaching, so I teach a lot of clinical classes at the School of Social Work, including anti-oppressive practice, anti-racist practice, and the new Afrocentric approaches in health and social care, which is a collaboration with Kimani Daniel from the Ingram School of Nursing, also at McGill. So we're already trying to do some types of collaborative work and decentering of Euro-Western perspectives in social care. So that's quite an exciting. It's new. It's, from what I know, it's the only course that exists in social services in Quebec of that nature. And it's quite exciting. So all of this kind of grounds where I'm coming from. And of course, the underlying piece here is what came out of my doctoral thesis. And so what brought me here, and Dr. Jarvis, probably when I was writing this thesis, your ears were ringing because your research has definitely been part of my my dissertation throughout. So thank you for all that work as well. And so what drove me kind of to this research is this perspective that, and what we most of you probably already know, is that there's this perspective that Black people are, so underrepresented in the use of voluntary services, or mental health services, but an overrepresentation in the use of emergency services and mandated health services. So they're forced by the police, they're forced by youth protection, they're forced by the urgency of the and nature of how the illness has degraded, and they're forced into involuntary hospital care. And this has been happening despite the fact that we've known, and the research has shown for decades, that the ethnocultural perspective and the ethnocultural context influences how people understand mental illness and how they understand the treatment. And it's also something that has been noticed and observed in common Western societies, such as Canada, of course, but the US and also the UK. So there's these similar types of observation. And in terms of theoretical perspective and framework, I'm also speaking to mental illness and psychiatry and mental diagnosis also as normalcy, and how each society has a perspective of what is considered normal, what is considered part of the normative discourse, and everything that's kind of not part of this normative discourse, of this normative way and codes of conduct, it will be considered as abnormal and consequently mentally ill. However, the ways and the ways and the perspectives and the behaviors that are seen as not part of this normative discourse will differ depending on social context and historical context and cultural context. And so that could be from rural to urban. It could be from a city to a country. So you can have different perspectives of what is considered normal within a same country, within the same nation. And so it's important to understand people's cultural background and cultural context to understand what they perceive and what they understand to be part of their natural normative discourse. And so this will then impact social representations, basically, or this pool of knowledge to speak to a concept and speak to an idea. So when we're talking about social representation of mental health and illness, it's the pool of knowledge that a person comes with to understand mental health and mental illness. And individual social representations cannot be separated from their culture, wherever that is, and whatever they present as. So no matter their racial or ethnic identity, what their cultural belonging and identity is going to have an impact on how they understand mental illness and mental health treatment, mental illness and mental health treatment. And what's also important to note is the impact of social representations of Black people. So, we're talking a lot about how Black communities are plural, they're pluriversal. Black people are not monoliths. Because we've often kind of gathered them together as this is what Black people do, this is how Black people are, and that's how they behave, and the impact of these stereotypes on how we provide services, how access to services is given, and then also how treatment is considered, or even the diagnoses that are being posed. So understanding that because with the history of colonization and slavery, and the impact on Black communities is that they were not seen as sufficiently developed to even attempt to have social expectation of modern life. And consequently, they could not suffer from mental disorders. So historically, Black people from Black communities have not been studied in a way to actually understand and observe their actual suffering from recognized and valid mental disorders. So Black people have often been studied to be objects of research as opposed to actors of research. And this is a new thing that's very recent, that's Black people are now in spaces to be actors of actual research, as opposed to only being speaking of. And in that same length, when they're seen as being objects of research, it's not the data that's gathered or the information that is gathered is not considered as part of facts or things that we could add to the common knowledge of things, but seen as folklore and beliefs. And so how do we understand these beliefs, but then get them to kind of let go of these beliefs and join the Euro-Western perspective and understanding of what health and illness is and how treatment should be given. And so what came out of my research, but what is also, and it also is seen in research other research on mental health and illness and social representation is that within the Afro-Caribbean community, within Black communities, there's 4 spheres of social representation. So the religious sphere, the spiritual and ancestral spheres, many ways to understand, depending on when people understand mental health, mental illness, and consequently, uh, treatment of mental health and illness, and how to go about actually healing and recovering, or being in recovery mode from mental health challenges. And this is significant because as I was mentioning. And so there's 4 of them, but I'm going to spend a little bit more time speaking to the religious piece and to the spiritual piece. But I'm still going to bring up psychosocial and biomedical for specific reasons. So what we're understanding from religion and in this context where we're in right now is also an important piece to understand in terms of the religion is more than just an institution. So when we're building policies, when we're speaking to société laïque, and we're speaking to religion as an institution, where institutions as any part of any system, there will be power dynamics. Institution can become dogmatic, but for people who are of Afro-Caribbean descent, and we'll see this in a lot of immigrant communities and racialized communities, and even in communities racialized as white, that religion also plays a community piece. So when we're speaking to religion, we're not just speaking to an institution, but also a community, and what does the community do and what the community has built, and understanding that despite when we're speaking about historically, the colonization had the desire to make sure everyone build Christian societies and step away from everything that was ancestral and spiritual and kind of traditional in terms of beliefs and healing, and wanted to head towards something that was more Christian based, but understanding that Black people were actually not always allowed into white churches, and even when they were allowed, there was segregational spaces in white churches, and that led to the development and that's part of the development of the Black church, where the Black church then became kind of the pillar of the community in terms of being able to respond to difficulties in access to services, difficulties in socioeconomic status, things that were related to socioeconomic status, things that were related to discrimination, fighting for people's rights to be human beings in society. The Black church has and continues to play a significant role, no matter the ethnic group. The Black church continues to have this role as community-based, as community support, as central to the development of people, even when they don't necessarily identify as Christian in terms of identity. The church still plays a big role in how people navigate it, and understanding that the church is open and the accessibility of services to the church. So technically, when you want to see your spiritual leader, or you want to engage in Bible study, or you want to join a prayer group, or even, there's no charge. It's free. You don't have to make sure your insurance covers this. So you don't have to have insurance to go and attend a church service or speak to a religious leader. There's no extensive admission process. You don't go through 5 intake levels to finally see someone that's going to help and support you. And they're available for those who who work non-traditional hours and have precarious schedules. People are not, and then there's an overrepresentation of people from Black communities who are working in these non-traditional and precarious schedules at work and are not able to take off at 2 o'clock to go see a medical professional or a mental health professional. So the church is available. It's open. There's service, at different times. There's availability on the weekends. People are available. And it also reduces barriers to racial discrimination when you're attending a church where people look like you. You don't have to worry about, okay, what do they think about Black people? What do they think about Haitian people? How are they going to see me? How are they going to understand me? So there's that part, and there's the familiarity with the religious leader. So when we speak to therapeutic relationships and when we speak to trust, this piece is already there. I know who you are and I know what I'm coming for. And so there's the unknowns are kind of broken down. And of course, what I'm not saying in any way that religious institutions and and the church is like the end all and be all of everything. Everything that is good to us must also be has critics and must also change. But it's important to understand that oftentimes we speak to the idea that people, particularly Black people, don't use the services because they don't know they're there or because of course, there's the mistrust, but there's also access. And when we're speaking to access and these differences in access is also maybe what's available for them at that moment. So it's not always that they don't want to go, but sometimes they just can't. And religion as identity. So people whose first identity before sometimes being Black is to be Christian. And so that Christian identity and Muslim identity, and so any religious identity that becomes part of this person's identity interacts and intersects with all facets of this person's identity. And so when we're speaking to policies that invalidate religion and invalidate religious perspectives and understanding, for some people, these policies and the way we act and the fact that we dismiss religion in a lot of our assessments and intake and in a lot of our treatment, we're also invalidating people's identity at times. And people who feel invalidated in their identity are not going to continue a process where they feel invalidated. And so it's also very important to understand where are people at in terms of religion, in terms of these perspectives, and in terms of these identity. And just because it's not part of their identity, it does not mean that it can't be part of a treatment piece. Yes, Dr. Jarvis.
This is really an important and interesting discussion. And I'm looking at your picture, and it looks like all women are in this picture. So I wondered if some of the Black churches were gender segregated, or is that just a chance picture here?
It's for me, it was a chance picture. I really enjoyed I enjoyed the women all wearing whites and being at church and women as pillars also of community, despite what despite what some of them want. But yeah, it was just a chance picture for me at this point. But it's a good question.
I think it's kind of significant since you're kind of raising the issue of how women in the Black community are so important. Mm-hmm. Have carried along a lot of the traditions. So here they, yeah. Anyway, I don't mean to derail the.
No, it's okay. It's a really good question. And so when we're speaking to also practice, and when we're speaking to things like treatment and treatment as a whole, because I'm coming from a social service background, the understanding that treatment is beyond biomedical perspective is how do we include these practices in the treatment plan? Sometimes religion, if anybody, attended a church service, sometimes that helps with meditation. It helps with grounding spaces. When we look at the Bible and, yes, it's a book, but when we're looking at certain verses from the Bible, when we talk about, affirmations, and sometimes this is also the role that Bible verses could play for somebody when they're in a situation and they're wanting to find words of affirmation. And so whose affirmation and how do we look at affirmations and how do we look at meditation? Is meditation only legit when we're, wearing yoga pants and Lululemon gear and we're going to a yoga practice? Or can meditation also be something that happens in a church or in a religious institution or with other people who come to your house to pray or to support you in a time, in a difficult time? And it speaks to the importance of collaborating also with pastors. The same way we think about individual service plans where we invite, the nurse, and we invite the psychiatrist and the social worker. If the pastor is involved or there's another religious leader that's involved, these people should also be part of the plan. So how do we work together? How are you observing this person when they come to your church? Does it look the same? Are there things that are happening when they're at church that help or hinder the recovery process? And at times people will say they're not necessarily not wanting institutional, like a psych talk therapy type of person, but they also want someone who is well versed in, who's Christian as well, and who's going to be able to understand them and have these conversations and these discussions with them. So there are these different pieces that are at play. And right now, the impact, I go back to policy a lot because we underestimate the impact of that in our practice and how we teach. And as I was talking to some community workers when I was doing my research, a lot of so when we talk about social representations, what we see is also that people who have a wider range of social representation are actually more open to a wider range of possibilities and options, as opposed to people who are more stuck into one way. And so when your social representations are solely biomedical or biopsychosocial, you're actually more closed off and less likely to speak to these other possibilities. So it's a lot of the reticence, a lot of the hesitation comes from actual professionals as opposed to the people. They know not to talk about it, or they're worried to talk about it because of the judgment. And we're going to talk about that, and also the ancestral piece. But if professionals are not bringing it up, it's also we're all kind of be in limbo in terms of how we pursue or how we are able to navigate interactions and therapeutic relationships with other people. And so I have had students who were told, in their training programs as social workers, not to talk about religion. And so when we're in a, focused on something like secularism, how does that then impact? So if we're told not to speak about it, as a as a method and as a profession, this will impact. And are we really trying to support people in their well-being and their recovery? So not everything that we're told to do is actually helpful for the people and centers the well-being of the people. So really considering these pieces when we're talking about religion. And spiritual and ancestral piece. And so the importance of ancestors, the importance of supernatural perspective, the consideration for supernatural perspectives, and traditional and plant-based healers. And what does that mean? And who gets to go and use plant-based healing? I have a friend recently, last year, who took a whole course in how to recognize edible plants in the forest in case they got stranded. But now we're in places like Haiti where plant-based healers and traditional healers, there's no one to take over. The youth aren't, for a multiple number of reasons, but it's also seen as something so negative that people are not trying to engage in this type of practice. So we're losing the plant-based, the traditional healing methods. And so whose discourse, depending on where you come from, whose discourse is allowed to speak these things out loud without being seen as someone who needs to be sent into the hospital and sent in, someone who's in psychosis or something, someone who's mentally ill. When they speak of the ancestors, when they speak of, I think my neighbor might have, sent a hex for me. When we're understanding, for putting this in a cultural context, in a socio-historical context, where in communities and in countries and in spaces where the social context has a limited resources and overpopulation, where there's literally, we are fighting for these resources. And how do I gain power over the fact that I feel powerless? And then also access. So it's not that people don't know that doctors exist. It's what in some of Caribbean countries, it's like one psychiatrist for 100,000 people. And then it's also having access or being able to get to a psychiatrist or get to a psychologist. So most people, if they're in underserved neighborhood, if they're more rural areas, if they don't have the finance and the means to access more biomedical services, then they are going to be using what's available and what's there to them. And at times it can also be seen as a protective factor where people feel like they have some power over their lives when they engage in rituals, in some types of rituals and some types of traditional healing methods. Sometimes you feel like, okay, this is happening, but there are these spirits that are watching over me, or the same thing with prayer. My grandma has passed, and for sure, this lady is still there, making sure that my life navigates well. Keeps me out of trouble when needed, and so there's that piece too. And recognizing that in general, Black people and Afro-Caribbean people, because of the history, have a history of mistrust. Like that's part of this transmitted, trauma and rightfully have mistrust. The medical system, Euro-Western medicine has been, and professionals have been, when I'm speaking of subjects versus, agents, Black communities have always been treated as subjects and as people that must then be, brought in to this normalcy of this perceived normalcy of Euro-Western perspective, as opposed to centering their realities and then understanding how do we work towards something that's closer to recovery from that space. And so speaking to spirits is not always, doesn't always speak to a mental health diagnosis. What does it speak to? Who's speaking to you? Asking these questions is also always very important, and it might be true. You know what I mean? Even a broken clock is right twice, twice a day. So if it worked one time, then we kind of, it becomes part of kind of this narrative. Yes, Dr. Jarvis.
I just wanted to mention, like, I think what you're saying can't be emphasized enough. Like, it's so important, and we're working with not just Black patients, other minority patients as well.
Exactly.
I often ask myself the question, how does my clinic space differ from the religious space? Like, let's say that my client goes to both places, and anyway, I think our clinic spaces are very different than the religious space that people may be going to for comfort or for help. Not all the patients, but some.
Mhm.
So I don't know. I think it's a question to think about, because I think it has a lot to do with trusting, like you say, or not trusting. If we can try to make our clinic spaces a little more toward the religious spaces, warmer. Warmer and less formal and more personable. Anyway, I don't mean to cut into too much to your talk at this point. At the end, we can discuss it more.
It's fine. Very legitimate points. Even, at the CLSC, a lot of people will tell you, what are these neutral, like the neutral colors are boring. They're not like, we look like a hospital setting. And it's also considering, okay, how can the clinic not be at the clinic? How do we also engage in some of these collaborations where people don't have to show up where we are in our offices, and how does that impact how people feel comfortable? It makes it more formal, and then we're more self-aware when we're in a more formal setting. So how does that also influence how we navigate things? And this picture was actually intentional, Dr. Jarvis, when we're talking about pictures. And so this is in Haiti. It's in Bois-Caïman, and it speaks to the preparation of the slave revolt in Haiti prior to the 1804 independence of Haiti as the first independent Black slave country. And so a lot of the history that comes from this is the fact that, and we see it in Haiti, but we see it in Brazil, and we see it in a lot of the global South, is the idea is and the understanding that the colonizers did not understand or have access to traditional healing methods, to the plant-based, what was the power of the plants, how can how the plants were able to function as positive or negative. And so a lot of the framework and the foundation for the revolution was based on traditional and spiritual and ancestral healing. So the dancing, the drums, really seeking the strength of the ancestors, and was an act of resistance. And so when we come at it from this historical piece, we could also understand why this is something that's been trying to, that we've tried to kind of demonize and pathologize and keep under wraps as something that's negative, and that's been internalized by both people from inside and outside of the country as something that is not good. But most people still, a significant number of people still are engaging in spiritual and ancestral work. And anything that's kept secret increases the chance and the potential for abuse. And so when we don't talk about these things, people who believe in that and who use these services often will be paying exorbitant money to have access to some type of traditional healer or healing rituals, even to some, concoctions that are not necessarily the right ones. People will use and be abused by people who see the potential in money and potential in abuse of people. And so when we're able to speak about these things also in session, we're able to, I always, the way I call it is the comme le mauvais client. So the same way, the same way that we have practitioners that are not, that we have psychologists that don't do their job properly. We have social workers that are not necessarily doing things the way they should, doctors, but there are boards for that where we could report to. But we should also be able, if we were able to open these conversations up with the people we work with in the communities, then we would also be able to say, don't go to this person. I heard, they're not actually conducive to anything that's going to be useful to you. Are being also able, so because people won't tell us that they're also engaging in different types of rituals, there could be counter indications in terms of medication, what's happening over there and what's happening at the hospital, in the clinic, in any of the clinical settings. And when we are able to, okay, what are you doing? What am I doing? How do we do it together? How do we navigate this? How do you see this happening? How do we engage in these? Because people won't necessarily stop their rituals. So how do we use it as something that could be useful? And then that we could also do educational work. But if we don't talk about it, and if we always pathologize people who come in speaking to spirits and to ancestors, we're not allowing this space for truth and for actually the well-being of the community and potential recovery. And also questioning whose alternative medicine gets to be gets to be named out loud, gets to be named in public. And why. So not everybody wants to always go to a medical doctor. People use, different types of hypnosis, acupuncture, blah, blah, blah. And these things are then covered by some insurances. And so how is it then? So that also plays out in terms of recovery. So what I believe in is not part of the dominant belief. And so therefore it can't be covered. And so recognizing how there's a variety of things that could be at play. And there are also one person that I have in mind is Ketelo. Ketelo is a counselor, but she's also doing ancestral and spiritual work. And so there's the professional that's combined with the spiritual piece. And so allowing people, allowing people to have access to maybe places of intersection that was going to help support them also in a better recovery space. Or how do we bring these people in then for also consultations?
Is Kay with the Black Healing Center?
Yes.
No, okay. I think I met her before.
Yes. She has a private practice, but she does a lot of collaborations with the Black Healing Center.
Mm-hmm.
And works a lot in the Haitian community.
Mm-hmm.
And so psychosocial, we technically have a biopsychosocial model, but we spend more time on the bio than the psychosocial. And when we're speaking to Black and Afro-Caribbean communities, African descendants, the psychosocial is also very important to understand beyond just, they're stressed and they're anxious. And when we recognize it as stress and anxiety, because oftentimes we're more likely to give stronger diagnoses to Black people than mood disorders and things like that, and recognizing how ethnic and racial identity has an impact on stress factors and capacity to cope. And so even if we refer someone to talk therapy, but if the professional has no awareness or capacity to engage in understanding social context as a racialized person, as an immigrant person, as a person who's born in Quebec, but still feeling invalidated because of their race and their ethnic identity, or because of their religious identity, that we're not speaking to the right issue. And we're just kind of putting band-aids on things, and you know, short-term coping, as opposed to actually working towards something that's closer to recovery. And here I want to also emphasize the importance of family environment and social environment and family environment. Euro-Western perspective focuses a lot on the individual, and we don't include always families, and it's you know, for better or for worse, family is there or is involved. And of course, you know, sometimes people don't want their families involved. We have to, you know, acknowledge and recognize that piece as well, or who they consider as family, so that it doesn't become also an isolating, an individual experience. Because at the end of the day, the social network and the community that the people identify with has a stronger impact than actual services. So the rejection of like community, whoever we feel is community, is has a bigger impact on people's wellness and capacity for recovery than the fact of not having services. And so when we take people away, or when we try to individualize things that are one social, but things that are so could also be supported by family environment, we're creating extra pressure, and we're actually hindering potential for recovery. And I also want to speak to intersection of identities with Black identity, because and it's also part of the community, the impact of being Black with a mental health issue also leads to rejection from the Black community, and then a lack of service from Euro-Western services, and other identities when we're talking about class, understanding other people. So it's not always just having Black bodies in these spaces, but really having the variety of voices that are there for representation, to understand, to truly understand what's happening, and truly being able to be supportive to the people who need it. And finally, yeah, sorry, there's something. Yeah. No. And finally, I wanted to touch on the biomedical in terms of also representation. So it's also something that people are going to use, and understanding that depending, and well, I'll get to that, but when I'm speaking of representation in terms of body, and which is different in terms of representation of voice, is something that, sorry, one of my participants, a really great demonstration of that, who in her head, so she was the only one of my participant who was really like, I understand mental health and mental wellness based on biological factors and imbalances in my brain, and so I need these medication and this connection of medication to help me get better. And so because she was Black, there's another organization that reached out to her to go and do some work with the Haitian family. And that's what the quote is about. And she's like, but they were talking about spirits and they were talking about other things, and I felt like I could not support them. And so the social representations become important in how we understand them, and how we value them, and how we're able to navigate within them to be able to actually offer the right and appropriate service. So if someone is really focused on the biomedical perspective, which happens a lot of Afro-Caribbean people come and study Euro-Western perspective, and they come back with this biomedical perspective that's not always helpful to the communities they come back to, even if it's their own communities. And so the perspective and understanding of the professional and the clinician is going to have an impact on also their capacity to do the work, and also being able to recognize, that's not me, I can't touch it, and I can't help you. And we have to acknowledge that as professionals and clinicians also, that we can't do, it's not just learning how to do something. Sometimes, especially when we come to social representations, a lot of people who are professionally trained in biomedical and biopsychosocial understanding, when they're in their personal life, will still be very involved, or very what will dominate their understanding of your mental health and mental illness in their personal life might be still very religious and very traditional and spiritual, even if at work they know that's what they're supposed to do and that's what they're supposed to speak of. And so, if there's not this openness, we can't actually get to the treatment that's going to lead to recovery. And so when I'm speaking to centering Black experiences, this is what I'm speaking to, because we have a model where Blackness, non-white, poor, marginalized, people of color is at the outside of the circle, and what's seen as normal in a biodynamic Euro-Western perspective is, white male, middle class, 2.1 children with a wife, etc. So, and then everybody else is kind of seen as not part of this norm that we're all supposed to be achieving. But when we actually speak to centering people, and in this case, it's Black experiences, but when we actually center people the way we say we're going to center people, that's what it means. It means, okay, we're putting the person at the center. And what are the things in this person's life that we need to consider and we need to understand and have at this table to actually bring them towards something that will be closer to recovery as opposed to just continued survival or temporary coping. And so when we're speaking to community, religion, traditional and spiritual beliefs and understanding and healers, and then family also are like these four big perspectives and important pieces that are at play and that should be always at the table. But of course, it's also understanding not all Black people, as I said at the beginning, navigate through this. And also, not all non-Black people don't navigate through this. So having this perspective of centering people, the person that's in front of you, so it could be, a person from another country, but that presents as white. There could be a Quebecois person, and that will be their circle. So I've intervened with Quebecois people whose this circle worked better for them in terms of really understanding religious beliefs, religious perspective, who's in their lives in that way, their traditional and ancestral perspective, who's their community, who's their family, way more than a typical Euro-Western type of tableau, type of graphic. And so how treatment is considered and what we've seen and what we understand and what kind of the research speaks to is that the person comes in with their social representation. We're able, when we're trying to understand and analyze and assess the situation, we're able to support and be okay with, okay, I understand that this is how you understand your symptoms. But when we get to treatment, we then only offer or consider biomedical and at times psychosocial. So sometimes we don't even get people into more of a psychosocial type of service. And when we center, and what I'm speaking to is how treatment should be considered. So understanding that what's happening at the forefront also needs to be considered when we're speaking to treatment, and recognizing that these four aspects or whatever five aspects that are holistic, that are important to this person need to be considered when we're also getting to the treatment part. And that's why we have a lot of difficulties as clinicians and as people and as my students when I get them to reflect differently. Okay, how would you work with this person? They still go back to very use protection and the medication and diagnosis, and have a really hard time undoing and getting more creative and thinking outside of this box that we kind of teach them to be in and how to get out of that box and be with the person. What is the person telling you? What are they speaking to? Because sometimes we hear them, but it's like, oh, okay, you're just talking, and then I think this is better for you. So we're also very paternalistic and slightly sometimes condescending as clinicians and as a system of, yes, we are centered and we want to support you and we want recovery, but you got to do it this way. We're not yet okay with doing it in a different way. And so what I want to highlight here as I end is the importance of collaborating and really sharing the spaces with the communities we claim to want to support, because we say it in the mouth. But the time that we have that's being constrained, the standardizations of our intakes of our services, the centralization of services makes it harder and harder to actually reach the people that we say we want to work with and that we want to support. And so how do we get into the community? I I have listened to Sharon's presentation, who was like, I have a list of, religious leaders and churches. And so we need to be engaging. They're not supposed to come to our ivory tower. We're supposed to be able to engage with them and see who are the people there in the community who are also, and a lot of times you'll have professionals in the community too. And if they're professionals and they're in the community and they're in the church, they also have like if we're able to work with them and engage with them, they're able to actually support and allow people would consider, are more likely to consider, another church member or another community member who's supportive of these services than just us coming in and saying, yeah, you should go to the CLSC or you should go see Dr. Jarvis at the hospital. It's going to be really useful to you. Um, and of course, and so this also helps to improve services within the community. So when we help the community, there should be, like a reciprocity. And that's also how you build trust in terms of, okay, you're not just coming in because you have this other research project to do and gather this information. You're actually coming in to educate, to do workshops, to highlight, and normalize. And we kind of need each other to be able to normalize and decrease stigma. Because when we all both stay on our ends and we have these great conversations, but we don't get together, we're also not moving. We're kind of at a standstill where we all agree there's an issue. We don't navigate it together. So that's what I wanted to speak to today.
Wow, thank you. That's excellent, excellent, important messages. If we think that routine clinical interventions are inflexible, wait till you get into legal issues.
Right.
The law of mental health is even worse, much worse. Anyway, this is a whole other issue. But I just
Mhm.
want to make a couple little comments because this was so important, I think, for everyone, clinicians and researchers. A quick correction. It wasn't Henri Darville who founded the Transcultural Clinic at Jean Talon. It was Carlos Terlin, MD. How could I make the mistake? I was just thinking about it during your talk. I went, whoa, wait a minute. It's Carlos Terlin, another important Haitian health practitioner. So anyway, and your idea about social representations leads into Stuart Hall's cultural representations. You might be interested to, I mean, probably you already came across his work. Um, the whole issue about religion in the clinic, I've been trying to introduce religion to the clinic for many years. A lot of people are not very happy with this effort.
Exactly.
I think patients are quite open to it, actually, but I think our institutions are surprisingly resistant. But when I was doing a research project long ago, and we're at the Jewish General Outpatient Department for in ICFP. Across the street is St. Paul's Anglican,
Mhm.
and the priest there, um, he when I went to talk to him, he said that a lot of your patients come over here after they see you, and they come over and see me, and I see a very different side to them. They tell me what doesn't work so well. So anyway, this is just an important. We should have more partnerships going across. I really would love to see that. I think you're advocating that maybe even traditional therapies could be brought in to healthcare. Like what if our insurance paid for 10 meetings with a bush medicine practitioner or something? That would be interesting.
Exactly.
Why not? We do massage therapy and we cover other kinds of like acupuncture. Why not bush medicine? And some people really want bush medicine. Anyway, these are just a few of my comments after your talk. I appreciate everything you said. We have a few minutes for questions. Anybody have any comments, questions for Professor David?
Yeah, I'm maybe interested in saying one word. Thanks a lot for this great work. I know it takes time to come with research, and I would like to know if you have some interaction with indigenous health researchers, for example, because I see many connection to this. And if you have, I was not there at the beginning. If you have some connection with Africa, I know in Benin and in Ghana they have made some work to come to have some department that work on African health, and yeah, I would like to know more about this. Thanks a lot.
Yes, that's a great question. So as I mentioned in the beginning, I also teach Afrocentric perspectives in health and social care, and all our guest speakers are indigenous to Africa
Okay.
and are bringing the connection between the traditional and the more biomedical perspective and how they've thought about doing the work and how they went back home to do the work. And we have a great
Mhm.
number of PhD students at McGill right now that are going to graduate but are from Ghana, Nigeria, and all their
Mm.
research is about this. And we had a great presentation on someone who was doing
Mm.
traditional healing and spiritual healing with people with dementia in Nigeria.
Mm. Great. Then I would love to come to see you.
So that'd be great. I
I
can
don't know
bring
if you know also about Geneviève Gagné at CHUM.
you.
Okay. With the clinic JAP, this is for young people with mental health. They have implemented
Yeah.
a new page on spiritual health.
Mhm.
Uh, I think it's this year or last year. So it's very, uh,
Recent.
yeah, recent. Yeah.
And we can put you in touch with her. She might invite you to come give a talk on spirituality and health and care for young people with psychosis.
Mm.
Sounds good.
Yeah, they have a new seminar series.
Okay.
Great.
So in
Thanks a
Nyanwi,
lot.
you're at the SHUM Nyanwi?
Yes, I'm the EDI advisor at the research center.
Oh, nice. Nice to
Yeah.
meet you.
Yeah, nice to meet you too.
Soyez le bienvenu.
Merci beaucoup.
Excellent.
Wonderful.
Any other comments or questions?
It's Friday. People have to go think and come back.
Maybe so. Yeah, no, anyway, we'll have to talk more about it, or what we can do to help to make this. I know we're working, and it's an uphill battle. It's upstream because of the secularism in Quebec and many
Mhm.
other places, not just Quebec, but lots of
No,
other.
for sure.
Yeah, so I mean, you talk about spirituality, religion, people immediately kind of bristle, whoa, whoa, like that sort of. But I mean, it's just on the ground. It's what people are doing, right? Like it's not. It's just there's just no question that it's part of life and part of person-centered care. So
Exactly.
ideologies are kind of that. They're ideas, and then there's practice, right? People are really doing. So
Mhm.
I hope we can find ways to introduce this spiritual religious component and make our clinics, our interviews, our interactions more warmer. I think it's a warmness people are looking for, right? It's not a distance. It's not a kind of a weird official labeling or something.
Exactly.
Yeah, I think that's what we're getting. When you're talking about religious rituals, people turn to in your talk, like it means that you're surrounded by people, right? Like it means that there's people there and they care about you too. It's all part of this. Whereas in a clinic, it's not so clear who cares about you. Maybe they do, maybe they don't. Your connections are more tenuous.
Yes.
At least at the beginning, you can develop good relationships with clinicians. But anyway, this is an important issue.
Well, thank you.
Yeah. Any last comments in our final dying minutes, Professor David? Any last thing you want to say as a summary for your work?
Dr. Jarvis, can I say something?
Oh,
Yep.
sure, for sure. Safe.
Yeah,
Go ahead.
yeah. So I connected from another phone, so fine.
Okay. I didn't think you could speak.
Thank you, Doctor. Thank you, Professor Syndie, for this very short presentation. It's very eye-opening too, and it's an important reminder. Um, what I wanted to say is that it's true that sometimes we may not have the right face or the right accent or the right last name or the right place of birth, and which all of us, whether all of these elements, whether combined or isolated, they can, you know, affect how we get to be treated by people in general. And what I wanted to say is that I think it's very important to balance between, you know, not seeing people of color simply as people of color. All right. In that sense, I think it's just very important that on one hand, for instance, I'll give you an example. You know, for the people would see me, they would think, okay, this guy is Muslim, Arab, or probably Indian, and so let's see how we can help him with things that pertain to his culture. So sometimes this also can have I'm not saying that we shouldn't do this, but sometimes it's very important to not see people of minorities as only a reflection of where they come from. I don't know if I'm making sense here. You know, I'm not. It makes more sense in my head, in the sense that, for instance, a black man does something, we'd say, okay, a black man did this. Whereas let's say a white man did something, we would say this person did it. So we would personalize it more, but we'll see that the people of minorities as acting or thinking in a way that reflects who they are, which can be detrimental whether we want to help them or want to stigmatize them. You see what I mean?
For sure.
Yeah, you can remember Professor David's diagram of intersectional identities. At the center was that person, was the person, right? So and then off, around that are different ideas of different identities, different contributions to identity. I think you have to keep that person in the center, like you're saying, safe, and that way we can avoid these stereotypes. The downside of all of our work is stereotyping, which sometimes happens inadvertently, often maybe. So
yeah, sure. If I can just give one last example that comes to mind now. I remember we had a case of a patient who was admitted for a first episode of psychosis, and one of her symptoms, or what appeared to be her symptom, was her being convinced that her in-laws hexed her with black magic. Now, I don't remember the case well, and personally, I was not involved in it. And I had a colleague who actually was an advocate of empathizing with minorities and all of that, and he said, no, how can it be psychosis? Of course it's part of her culture. But the thing is, saying it's part of their culture with empathy or with seeming empathy can also be detrimental. You see what I mean? Because if you isolate this element on itself, yes, there's something culture in it, but if you look at the whole picture, you would see that the person still needed help. And so saying, oh, that's them, 98% of the world believes in spirits, so schizotypal doesn't exist. So I think this can also be hurtful because, I come from a country where people believe in spirits, but they don't actually actively think of them. And psychiatrists themselves, they do diagnose schizophrenia and do diagnose schizotypal personalities, even if they themselves believe in it. So saying that this person who comes from this culture believes in this, so okay, there's nothing pathological about it. So I'm not all for pathologizing everything, but not for, all the time saying, okay, this is them. You see what I mean?
Yep. And that's exactly what I'm saying. And that's the problem, is that we're only seeing culture in the other. We're not seeing culture in the dominant group and understanding that we're right now in somebody's culture. And so if we make the habit of always asking everybody and exploring things all the time, aside from culture, but understanding that all of these pieces and how people understand things is way more important, because we could be two different races and have the same culture.
Absolutely,
but we
yes.
don't.
So what I retain the most really today from you, Professor Syndie, is to always remember to center the person, between their individuality and their culture too. Not let one prevail over the other.
Exactly.
I think so. It's a good summary.
Yeah, and definitely not excusing culture. We do that a lot, yes. Doesn't mean that something's not wrong and that they don't need help.
Of
I
course.
mean, all of our beliefs and expressions are culturally embedded, right? They can be
Exactly.
healthy or unhealthy. I mean, it's all embedded. So it doesn't, just because somebody has a cultural part of that they're talking about doesn't mean that it's necessarily um, healthy or unhealthy. We have to we use that knowledge to start making a careful evaluation
Yes.
and see how we can inch forward, crawling forward humbly, to make the best decision. So
Well, yes, great point.
this is wonderful. Thank you for all of your input.
Yes, thank you.
I see that we're
Thank you.
past.
Have a good Friday.
Yeah, you
You
too.
too.
We're
Enjoy the
past.
rest of your weekend.
We're past 12 noon, so we're going to have to wrap it up.
No problem.
Thank you very much.
Thank you.